Assalamu alaikum. Welcome back to my channel. Today we study VSDs as its types and the parameter of the size. Understanding ventricular septal defect is the most prevalent congenital heart defect characterized by an abnormal opening in the intraventricular septums which result in left to right shunting of the blood. The management of VSD varies based on the size of the defect and the symptoms presented by the patients. Fortunately, most individuals exhibit favorable long-term outcome following surgical closure of the defects. Introduction to the ventricular septal defect is commonality. VSD is the most prevalent congenital heart defect affecting many infants and children globally with varying degrees of severity. Pathophysiology is the defect permits blood to flow from the left ventricle to the right, increasing pulmonary blood flow and potentially causing complications. Symptoms smaller VSDs are often asymptomatic, while larger defects may lead to congestive heart failure, growth issues, and characteristic heart murmur. Embryology and anatomy of the ventricular septum. The development of the ventricular septum is essential for proper heart functions. Defect in its structure can lead to serious health issues. Understanding the types of defects and their location is critical uh, for accurate diagnosis and management. Membranous septum defect, the most common types of defect, emphasizing its anatomical significance. Types of defects include perimembranous, muscular, inlets, and outlets. Diagnosing Diagnostic importance: identifying the defect locations is vital for management. Type of ventricular septal defects: perimembranous, the most common types located beneath the aortic and tricuspid valves, often leading to clinical symptoms. I will show you the diagrams and the real echo clips after this. Muscular or trabecular, found within the right ventricular muscles, may present as multiple defects, complication assessment and management. Outlet supracrystals, position near the pulmonic valve. This type can complicate surgical interventions and requires careful planning. Inlet, a rare type near the interventricular canal, often associated with other congenital anomalies, necessitating through evaluations. Look at these diagrams. All the VSDs types are labeled here. After this diagram, I will show the real clips also. In the parasternal long axis window, you will see the perimembranous or outlet as like in 5 chamber. Both are the outlet perimembranous VSDs here. If the VSD appears in the 5 chambers, so this is called perimembranous outlet VSDs. And if the VSD present in the 4 chamber appear in the 4 chambers, so this is called the inlet VSDs. And look at the short axis view. In the 11 o'clock, this will be the perimembranous VSDs. And if the VSD appears in the shunt appears in the 12 o'clock, this is called the outlet infracrystal VSDs. And Also, the second name is subaortic VSDs. And if the VSD appear here, the near to the pulmonic, so this is called supracrustal outlet VSDs. Second name is doubly committed, and also some people call it the subpulmonic VSDs. So never be confused in the VSDs names. There is multiple name of the single VSDs also. So look carefully in the diagrams and you will know which type of VSDs and where is located. In the 4 or 5 chambers, the upper septums, like the uh, red diagram there showing the red area. This is the muscular or trabecular place of the septums. So if the VSDs appears the apically, this will be called apical muscular VSDs. And if the VSD appear in the mid septum, this is also called muscular, but high muscular VSDs, and label it. So I will show now the real video clips. Look at this short axis aortic valve window. The blood from left to right shunting at 11 o'clock. So this is called the perimembranous septal defects. Look at this clip. This is also the aortic short axis window, and the blood from left to right shunting at 12 o'clock. This is called subaortic VSD or outlet infracrustal VSDs, as I show you in the diagram. So this is the 12 o'clock, and this is called subaortic or outlet infracrustal VSDs. This is also appear in the 5 chamber window. When you see the 5 chamber VSD, so look at the short axis view. The shunting from left to right will be at 12 o'clock. This is the subcostal 5 chamber window with the ventricular septal defect from left to right shunting. So this is the same patient which you see early the short axis window, the blood shunting at 12 o'clock. This is the subaortic or outlet infracrustal VSD. This is the real clip. The apical chambers with the apical VSDs. The blood from the left to right shunting. So this is called the trabecular or the muscular apical muscular VSDs. But there is multiple apical VSDs. The second VSDs here, and the first or second both VSDs, multiple VSDs are apical VSDs here you have seen. As we study, the apical muscular VSDs are sometimes multiple VSDs appears. So watch the video from the blood from left to right shuntings. Multiple VSDs are appears here. And this is the gradients at that VSDs. This is only the image I have shown you because the high muscular VSD mm, video is not available. So this is the high muscular septum and the blood from left to right shuntings. This is called high muscular VSDs, and you see the previous video apical muscular multiple VSDs also. And shunts mechanism, the abnormal flow from the left to the right ventricles alters the normal hemodynamics affecting overall heart functions. QPQS is more important ratio. The ratio assesses shunt severity. A normal ratio is 1:1, while a significant shunt is considered greater than 1.5 ratio 1. The QP means pulmonary uh, to systemic QS flow ratio. So this is more important, and the VSDs and ASDs. If you don't understand the QPQS ratio, then comment below. I will make another video for this. Complication: the large shunts can lead to pulmonary overcirculation, volume overload, and increased risk of Eisenmenger syndrome. The QPQS ratio is also for the Eisenmenger syndromes. Clinical presentations of VSDs: small VSDs, generally asymptomatic, may be detected as the loud systolic murmur and at the left lower sternal border without sign of heart enlargement. Moderate or large VSDs symptoms can include failure to thrive, dyspnea, and recurrent respiratory infection, indicating more significant hemodynamic impact. Sign of heart failure clinically finding may include hepatomegaly, a wide point of maximal impulse, and characteristic murmur after a long side respiratory issue. Echocardiography views, as I show you the 5 chamber view, short axis view in the peristernal views. So this is also the peristernal long axis, the critical for visualization perimembranous defects and adjacent structure of the septums, aiding in diagnosing. Peristernal short axis view useful for the aortic level for assessing and confirming the presence of VSDs. Apical 4 chamber effective color for color Doppler imaging across the septum, allowing evaluating of shunt flow and direction. Subcostal views, particularly advantageous in infant, providing clear visualization of anatomy, especially for the bulky defects. Management of ventricular septal defects is, so this is the journal measurements. A small VSD is less than 3 mm. Upon close spontaneously, regular follow-up echocardiography are recommended to monitor for changes. Moderate VSDs is 3 to 6 mm. Medical management is advised if symptoms arise. Surgical closures as typically recommended before school age. Large VSDs greater than 6 mm require medical support, diuretics, ACE inhibitors, and often necessitated surgical patch closure with the first year of life. Indication for surgery include significant shunting symptoms of heart failure, failure to thrive, and recurrent respiratory infection. Catheter device closure may be an option for selective muscular VSDs. The VSD size is matters because it is a congenital defect and may diagnose accidentally at an elder adult ages. Therefore, its parameter from small to large also affect. So, therefore, a basic measurement method at all ages compared The size compare the size of VSD with the aortic annulus diameter. VSD is considered small if the diameter is equal or less than 1 by 3 of the aortic annulus diameter. Moderate of its diameter 1 by 3 to 2 by 3 to the aortic annulus diameter, and large of its diameter is more than 2 by 3 of the aortic annulus diameter. So I hope you will understand the VSDs, the type of the VSDs, and the size of the VSDs, how we take the size of the VSDs, and the hemodynamics also. Thank you for watching. Subscribe my channels.